Sometimes we get asked by listeners, can you please make your podcast based on trimesters or in chronological order of a pregnancy? Which I am sorry, after a few years in of publishing our podcast, the horses bolted on that one a bit. So we got to thinking, what else can we do to make it easier for our listeners? We have a solution. Pat and I have written a week-by-week newsletter which follows along your pregnancy and gives you tips and links to the relevant podcast and other value content we have published. Best of all, it's free, and you can sign up with your due date at growmybaby.com.au at any stage of your pregnancy.
The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got a topic that I think is, common.
Yep.
Yeah, people know about herpes, but do they really know about herpes in pregnancy?
Yeah, I think it's really relevant because, herpes infections can be recurrent, and the same person who struggled with a few recurrences of the virus over their, teens and 20s, one day they might want to be pregnant. It does have important manifestations in pregnancy that we need to discuss.
I want to start by asking, what is the difference between a cold sore and genital herpes?
We normally use the word cold sore to describe the lesions on your lips, right, on your face, and they are typically caused by subset 1 of the virus, herpes simplex virus 1, but not always. And then there's the genital sores, which are usually herpes simplex virus 2, but there's some interaction. Sometimes the facial ones are 2 and the genital ones are 1.
And you wouldn't really know the difference unless you got it tested. There's no difference in the lesions, is there?
No, not really. No. So anyone who's had the herpes cold sore virus on their lips knows that it can be recurrent, that they're irritating and painful, that they can pop out when you run down or overexposed to sun or too many late nights. Or when I was a hospital doctor treating a patient in the emergency department who had a really bad case of cold sores, and she was telling me about how she'd been not looking after herself, too many late nights, drinking too much. And I said, probably should stop that. And
how old were you when you said that?
Yeah, and I was like an intern, and one of my mates was listening from the next cubicle and just went. So, they're kind of part of life for young people. But for today's purposes, we're really talking about the genital lesions and their importance in pregnancy.
I want to just tell people about my uni days, and I was just probably like a 18-year-old straight out of home and going to the doctor by myself for the first time about something totally unrelated to the cold sore on my lip. And all of a sudden I had this GP talking to me about, you do realise that you can't be giving oral sex because of the cold sore on my lip. And I just was so embarrassed. I think I just picked up all my pieces of paper or whatever and just left.
If I'd known that was going to be mentioned, I would not have come, sir. Look, the relevance of the facial lesions to pregnancy is really just that if you've got one of those when you're at full term, and the baby's susceptible to the virus within the first month and can become seriously unwell. So the problem with having a facial lesion when the baby comes is you really shouldn't be kissing the baby. And that is, sad.
Yeah.
And upsets people. And it can be worth discussion of suppressive therapy late in pregnancy for someone who's had multiple outbreaks of facial herpes to prevent it happening at term.
Yeah.
Avoiding kissing the baby, even though it's sad, it's something we could also do.
Yeah.
The genital lesions are more serious because if the baby comes out through the genital tract and picks up herpes from a lesion on the vulva, it can be very, very serious.
All right, and I do want to get into that. just to highlight how common this is, the WHO says that about 64% under the age of 50 have the HSV virus, HSV1 virus, and about 13% aged between 15 and 49 have the HSV2. So that's really common, isn't it?
Yeah, super common. Yeah.
And people, as you said, can have both. So tell us, why are we nervous about herpes in pregnancy?
Well, often the lesions we're talking about are recurrent. Mm-hmm. So just as you could be, if you've been exposed to herpes in the past and had a couple of little blisters on the labia and then they went away, they tend to come back at times when you are run down, overworked, too tired, poor sleep, and so forth. And a lot of those conditions apply to late pregnancy. So a recurrence in advanced pregnancy is a real possibility. The thing with herpes is the diagnosis is often not that difficult because they hurt. Yeah, and painful genital lesions are unlike most of the other genital lesions. If it really hurts, that needs to be checked for herpes.
And it would make someone go to the doctor then.
Yeah. Take a swab and get diagnosis. But, if you're prone to recurrences and you might get one at term, then the danger is that you could have a subtle lesion. The baby could pick up the herpes on the way out during the birth process and become seriously unwell.
And what does seriously unwell mean?
In a high-risk situation, paediatricians would look at things like, babies that had any sign of any serious illness, like listless or abnormal observations, fevers, or an actual rash with blisters.
Oh wow!
And the paediatricians do an amazing job because sometimes the sign of a baby becoming significantly unwell is something as subtle as poor feeding.
Yeah, right. Yeah. And gosh, it could be so many different things. Why that baby's sick.
And you can't ask them. So this mostly comes down to history. This is us saying to the paediatricians, this person is at risk.
Yeah.
Yeah.
And is it like CMV, the episode that we did a few months or weeks ago, where if it's your first time, it's worse?
It's worse, definitely. Yep. So you've got a much higher viral load and much more likely to have viremia the first time around. So that means that there's actually virus circulating in your whole body and your bloodstream. So the woman in a primary episode is much more likely to have severe genital lesions and be systemically unwell with fevers and dehydrated and sick. Whereas recurrences are painful and irritating, but typically confined to the area where the recurrence is located.
Yeah, right.
Yeah. So, and I think the viral load is much higher in a primary episode. So the paediatricians are much more concerned with someone with a first episode of herpes happening at the end of the pregnancy than they are typically with a recurrence.
And does that go for like the HSV one, the cold sore type?
I guess so. Although that's much easier to manage because you can cover the lesion on the face and you can avoid kissing the baby.
Yeah,
and that I think those changes to behaviour, those interventions are typical, whether it's first or subsequent.
Yeah,
infection.
And also those tough conversations that you have with people that kiss your baby.
Yes, well, this is one of the reasons why we shouldn't do that.
Yeah,
yeah.
I just can't think of kissing somebody else's baby. Like, I've got to that point that I find it abhorrent. Like, I don't want to do it.
Yeah.
As much as my whole body's going, oh my God, what a gorgeous baby.
Yeah. I think COVID's done a fair bit to recalibrate our tolerance for connection with other people.
Yeah.
I honestly think that. I think it's done a bit to calibrate it back the other way, away from that super close contact with people where that's not strictly necessary.
Yeah. No, it's just a boundary that my body just recoils from now. Yeah. So Pat, let's go on to when the baby's due and someone has an active lesion. What are the discussions that they're having with our care team at that time about delivery?
I want to take you back a little bit further than that because the name of the game is to prevent the active lesion at term. So if we go back, if someone's had multiple recurrences across their early life or multiple recurrences within that pregnancy, then I would be talking to that patient about being on suppressive therapy to dramatically reduce the chances of them getting that lesion at term. And you can take a drug called acyclovir, an antiviral drug that's very safe for use in pregnancy. It has no known risks in pregnancy. And you have to take the pills a lot. There's like 5 doses a day or something.
God.
But it's very effective at reducing the activity, and that's our best defence against getting an episode at term. But if you get an episode at term nonetheless, then the baby's better to come by a cesarean section.
So is there any way of treating so that's taking it just to prophylactically, but is there anything, if you've actually got an active lesion, are there other medications that you can take?
Well, you can take pain relief and you can take acyclovir to shorten the illness. But if we're talking at term, you haven't got that time, it needs to be totally resolved if you're going to be back on track for a vaginal birth.
And totally resolved means that there is no lesion present.
Yes, yeah. And even then I'd be getting expert advice if it was close to the delivery because viral shedding from things can go on longer than you appear to have recovered.
Yeah.
And the problem is that an infection in a newborn from some of these viruses, they're serious.
Is it only through delivery that a baby can get herpes, or can the baby get herpes in utero?
Yeah, there is an in utero form. It's not very common, but in particular, if a woman's got a primary episode during pregnancy and is particularly unwell, there is a possibility of the baby catching it during the pregnancy. And like some of those other viruses that we can get during pregnancy, like rubella and CMV, they can cause all sorts of problems with the developing baby. So there's a thing called a torch screen, which is a blood test done during a pregnancy if there appears to be a chance that a baby might have picked up something during the pregnancy. So it looks for antibodies for toxoplasmosis, rubella, CMV, and herpes. So we would do that test if we were investigating a baby that had died in utero or was way too small or had ultrasound evidence, for example, of abnormal organ development or calcification within internal organs, so things that would show up on an ultrasound. And the torch screen would be used to see if infection was behind that, and occasionally some of those would be in utero herpes.
If someone that you suspect their baby's been affected by herpes in utero, would you send them to, say, a maternal fetal medicine specialist?
Yeah, so go to our episode where we discuss maternal fetal medicine services with Professor Joanne Said. Fantastic. That's one. So these are services that give expert advice on these rare things.
Yeah.
So absolutely, if I saw one of my patients and baby looked too small, and we did an ultrasound and it looked like there could have been in utero infection. What does this mean? Is my baby going to be affected by this? Is my baby going to die? Is my baby going to be physically or mentally affected by this infection? Where do I get this information? Rare thing like that, I'd be on the phone to Joanne and say, here's the situation. I need your expert guidance and to be able to appropriately counsel my patient.
What advice would you give to people that perhaps in a couple, the partner has herpes?
Yes.
What can they be doing to prevent any sort of infection to their baby?
Yeah, I think that it's different for the partner. Let's say we've got a couple there's a male partner who's had some recurrent genital herpes. The medications to be used by a non-pregnant person to suppress outbreaks are easy to take. There's once daily dosing. And so these are very, very effective medications that you can just take one dose a day forever and have very few or no outbreaks. And that's definitely something that somebody should be considering if they've had more than about an outbreak a year because they're painful and awkward. And so some people are just on suppression, they never get an attack and they're fine. If they're not on suppression and they get an attack, then obviously want to avoid intercourse until that episode has resolved, because if the partner's never been exposed, then they want to be exposed now.
Yeah.
So that advice would be standard in or out of pregnancy.
Yeah.
To respect the safety of your partner and try and avoid the transmission.
So, Patty, if the baby has unfortunately been diagnosed with having herpes at birth, what would the parents expect in terms of treatment?
Yeah, so it's a serious situation. The paediatricians are going to be managing this very diligently, and there's a list of things that they would look at to work out how significant the risk to the baby really was. So they need to know whether the mother was having a primary or secondary episode. the primaries are obviously worse. Whether the mother had developed mature antibodies to the herpes virus herself, whether the baby was snuck out vaginally or born by cesarean section, how long the membranes were ruptured in labour is highly relevant. And also the integrity of the skin. So if the baby came out with no damage at all to the skin on the head, that's better because the skin provides a barrier to infection. Whereas if we've breached that membranes by that integrity by the use of a fetal scalp electrode or a vacuum cup with tear on the skin, then that's worse. And whether the genital lesion on the mother was type 1 or type 2. All of those things are relevant in the mind of the neonatologist as to how risky the situation is. And then obviously they work through protocols and treat the babies with antiviral drugs in a low-risk situation for a matter of days and in a high-risk situation for months.
Yeah, wow. And so when you say they have to work out whether it's HSV 1 or 2, if they've had an active lesion before the actual delivery, would it be routine to take a swab to find out?
Yeah, ideally we would know that.
Yeah, to have as much information as possible for that woman as she goes in. Okay. Would it be useful if I made a little summary of what I've heard and then you tell me if I've got it right?
Sounds good.
Okay. So firstly, if you've never had herpes, and it's your first infection, watch out for like systemic problems like body aches and fevers. Yep.
Yes.
To see if it's an active, because the active one is more of an issue.
Yes.
Yep, good. If you have had recurrent herpes, then you might talk to your doctor about an antiviral during your pregnancy.
Yes.
Yep.
To decrease the chances of you having a lesion at term.
Yep, good. If you've got an active genital lesion, you might be advised to have, you will be advised to have a cesarean section.
Absolutely.
Good. And prevention is the key in the first place.
Yeah.
So I don't know how in pregnancy you stop the stress and the tiredness and the fatigue. But
in my experience, most of people affected by this problem have had a primary episode when they were 19 or something, and they've had a couple of recurrences since then.
Yeah.
And they know what they feel like. They're familiar with the little tingling and the pain, and they'll bring it to your attention. So take-home message is if you think you are getting a recurrence of a genital herpes lesion in advanced pregnancy, bring that to the immediate attention of your caregivers.
Yeah. Don't hide herpes.
No.
That might be the slogan, don't hide herpes.
Super important.
Also, and this is difficult, if you've got a cold sore, don't kiss the baby.
Yeah.
Yeah, be careful when you're breastfeeding. It's sort of easy just to brush your face up against your baby.
It seems with newborns, they've just come out of sterile environment inside their mother, and they have an immune system that works okay for lots of things. They're immediately exposed to dirt and God knows what, and they cope very well with all of those pathogens that they're exposed to in the early days of life. But there are a couple of problems. There are things that are vaccine preventable, but they don't get the vaccines till later on. I'm thinking whooping cough, for example. And then there are things that they're just really bad at fighting off. GBS, which we've discussed in the past, and this family of viruses that can cause overwhelming infection.
And so on the kissing of the baby, sometimes you have to have those difficult conversations with your near and dear to say, please don't kiss my baby.
Yeah, so I think that advice we give family members to don't come and visit the baby if you've got a cold, 100% that also includes if you've got a orolabial herpes lesion on your face.
Yeah, and if you're like me, I can predict within a day if I've got a little bit of sunburn on my face, I will get a lesion on my lip. So,
yeah, it seems to be particularly promoted by sunburn.
Yeah.
Yeah.
So that's another way you can prevent it. All right, how did my summary go?
That's pretty good.
Oh, good. Okay.
Yeah.
All right, everyone. Well, I hope that gives you enough information about herpes. It's such a common virus. 2/3 of the population has HSV1. So I hope that gives you enough information that you can be the full bottle when it comes to herpes in pregnancy.
Perfect.
That's it for this week.
Thanks for listening, everybody.
Have a fabulous week. Bye for now.